Hey everybody, today we're going to be covering congestive heart failure. It's going to be part of the cardiac series that we have been covering this summer. It's going to be separated into two parts. It's going to be separated into part one, part two. Part one being the pathophysiology and nursing interventions that's associated with it. Part two is going to be associated with the diagnostics and the treatments. So let's get started. So starting off, congestive heart failure is the inability of the heart to pump and fill properly during systole and diastole. So what's going to happen is that if the heart is not pumping properly, therefore there's going to be a low cardiac output going out to the systemic circulation, and therefore there's going to be low tissue perfusion. When there's low tissue perfusion, patient's cells are going to build up with lactic acid, therefore leading to issues such as ventricular tachycardia and ventricular fibrillation. I think it's important to discuss the blood flow of the heart before moving on to the signs and symptoms of right-sided heart failure and left-sided heart failure. So let's begin. So it begins with the superior vena cava and the inferior vena cava bringing in blood flow. Superior vena cava brings in blood flow from the head and neck. Inferior vena cava brings in blood flow from the lower extremities. Deoxygenated blood flow meets at the right atrium. The right atrium is where low pressure is standardized. What happens there is that deoxygenated blood travels through the tricuspid valve to the right ventricle, where it's highly pressurized. The right ventricle then pushes out blood to the pulmonary valves, and then blood flows through the pulmonary artery, which is considered to be the only artery in the body that contains deoxygenated blood supply, to the left lung, where that blood is oxygenated. So from the left lung, the lung is going to send blood through the pulmonary vein into the left atrium, where it's considered to be a low pressurized system again. The blood is then going to flow from the left atrium through the mitral valve, or also known as the bicuspid valve, to the left ventricle. The left ventricle is going to be considered to be highly pressurized, where it's going to send out blood through the aortic valve into the aorta and out to systemic circulation. So the compensatory mechanisms that's associated with congestive heart failure, it begins with the sympathetic nervous system, which is the fight or flight. It's the first compensatory mechanism to turn on. So what happens is that when the kidneys detect that the heart is not pumping out systemic blood flow properly from low cardiac output, the kidneys are not being perfused. So what's going to happen is that the heart rate is going to increase and blood pressure is going to increase to compensate for the rest of the body. The second compensatory mechanism that's going to kick on is RAS. The kidneys are also going to detect this as well due to low perfusion, since the heart is not pumping out blood properly. So what's going to happen is that heart rate is going to increase, blood pressure is going to increase from angiotensin 2 and the use of aldosterone to supply to maintain that blood pressure overall. Antidiuretic hormone will also activate when the brain is detecting that there's not enough perfusion. So what's going to happen with that? Blood pressure is going to increase as well. So the trend with most of these compensatory mechanisms is that heart rate is going to increase, blood pressure is going to increase to compensate for the rest of the body. Okay, so what causes right-sided congestive heart failure? Well, the number one cause of right-sided congestive heart failure is left-sided congestive heart failure. So why does that happen? Well, it begins with the right side trying to compensate for the left side's issues. So if the left ventricle is unable to push out blood to the systemic circulation, and then blood flow is backing up into the right side of the heart, the right side is going to have to compensate by pushing out deoxygenated blood back to the pulmonic valve, to the pulmonary artery, and also trying to compensate for the left side by bringing back oxygenated blood out systemically. So what's going to happen is that the right ventricle could possibly hypertrophy due to the overuse of that muscle. For the second reason why right-sided CHF happens is that the right ventricle is insufficient, meaning it could be floppy or it can be stenosed. If it's stenosed, there's going to be a narrowing, and when there's a narrowing, it's going to have to work much harder, and then over time, that ventricle is going to give out. Therefore, it's not going to be able to pump out that deoxygenated blood flow to the left side so it can pump it out systemic. Third reason is that the tricuspid valve and the pulmonic valve could be insufficient. So these two valves over here could either be damaged due to some kind of from a disease process, or it could be stenosed, or it could be floppy. So there is a trend here that there's either a valve malfunction or a ventricle malfunction within the right side, which leads to that right-sided CHF. So what are the sinus symptoms of right-sided CHF? Well, when you're thinking about the sinus symptoms of right-sided CHF, think systemic. Where most people confuse left-sided and right-sided is that left-sided is actually has to do with the respiratory system mainly. Right-sided is systemic. So let's talk about that. Let's say we have an insufficient right ventricle that's not able to push out the oxygenated blood supply to the left side of the heart. Blood is going to seep back through the tricuspid valve into the right atrium, which is considered to be low pressure. That blood is going to flow through the superior vena cava into the head and neck. So that's where we see our first sinus symptom: increased jugular vein distension. So when the blood flow is flowing back to the neck, we're going to see some large veins. Second, we're going to see ascites because blood flow is going to be flowing back down to the inferior vena cava. So our body's going to compensate by increasing the amount of fluid in that area, and so that's why it's very important to weigh CHFers who have right-sided or left-sided heart failure. Typically, this accumulates within the abdomen. The third sinus symptoms for right-sided CHF is hepatomegaly. This is the enlargement of the liver. So now, due to the blood flow flowing down to the inferior vena cava, the liver is not going to be able to function properly, and the liver has a lot of functions such as clotting factors, detoxification, drug absorption, and it also helps with converting bilirubin. So some things you would want to trend is the patient's AST and ALT levels. Is that elevated or not? What's their bilirubin levels like? Make sure to assess their skin color. Also assess their sclera. Is it yellowing? Fourth sinus symptom for right-sided CHF is peripheral edema. So this is when the lower extremities are swelling. So patients will be complaining of that. Typically, if you're having a difficult time trying to get a pedal pulse, that's when you're supposed to use a Doppler ultrasound to detect that pulse. Some medication that could help with that is like a water pill, such as like diuretics, such as Lasix. Okay, so for left-sided congestive heart failure, it's important to separate it into two separate factors. There's systolic and diastolic. So let's talk about systolic really quick. Systolic is the inability for the heart to pump. The first cause of systolic left-sided heart failure is myocardial infarction. So why wouldn't the heart be able to pump if the patient experienced a myocardial infarction? Well, it's because during a myocardial infarction, after the ST elevation occurs, that means there's an infarction. Therefore, the muscle has necrosed and it is dying or it is dead. So if a muscle is dying, it's not going to be able to pump out blood to a systemic circulation. Therefore, the patient can have low cardiac output and low tissue perfusion, the increased amount of lactic acid, and so on. The second reason is dilated cardiomyopathy is when the walls become thin and then the heart becomes big and boggy. When the heart becomes big and boggy, it becomes tired and it's ineffective in pumping blood out to systemic circulation. Third cause for systolic left-sided CHF is mitral valve or aortic valve insufficiency. Mitral valve is located in the left side of the heart. That's where blood is sent to the left ventricle to pump out blood to the systemic circulation. If the mitral valve is insufficient, or is damaged, it will have a difficult time pumping out blood to the systemic circulation to bring out that cardiac output to the rest of the body. The next type of CHF is diastolic. Diastolic congestive heart failure is the inability for the heart to fill. So what could cause diastolic CHF to occur? Well, the first cause is chronic hypertension. Chronic hypertension is when the patient over time has a high blood pressure, maybe hasn't realized it, the heart is trying to compensate, and the walls become hypertrophied. When the walls become hypertrophied, the heart will not be able to fill properly. Here are your walls of the heart. Over time, the heart compensates by gaining muscle, and there's not going to be enough room in the chambers, in the atrium of the heart to fill during diastole. Restrictive cardiomyopathy is the inability for the heart to stretch during diastole. So if the heart is unable to stretch, it's not going to be able to fill properly, therefore low cardiac output is going to occur. The third cause for diastolic left-sided CHF is hypertrophic cardiomyopathy. It's very similar to chronic hypertension when the walls become thicker and become more swole due to the overcompensation. So during diastole, the heart is not going to be able to fill properly, therefore leading to low cardiac output. Aortic stenosis is the fourth cause for diastolic left-sided CHF. Aortic stenosis is when the aorta becomes stenosed, meaning it becomes narrowed. It could have occurred from coronary artery disease. That narrowing causes other muscles to compensate for that structure. And what happens is that when other muscles compensate, they become hypertrophied due to having to work harder, and that means there's going to be a less filling time during diastole. Okay, so what are the signs and symptoms of left-sided congestive heart failure? Well, as I mentioned earlier, left-sided congestive heart failure has to do with the respiratory system, so we're going to see some signs and symptoms associated with that. So let's say if we have blood flow. Let's say if we have blood flow flowing back from the left ventricle to through the mitral valve into the left atrium, back into the lungs. Now we have fluid accumulating within the lungs. It's going to disturb the alveoli gas exchange. So we're going to see a lot of cyanosis. So that goes to the first sinus symptom, as a matter of fact. First sinus symptom is the patient is going to become cyanotic. They're going to be blue. Assessment, make sure to look at their skin color, look at their nail beds. Is there any clubbing of the fingers? That all has to do with the gas exchange occurring within the lungs. Patient's O2 stat is going to be low, possibly lower than 88. So it's important to make sure to have this patient on nasal cannula. Third sign of symptom is the patient's going to be dyspnea, and they could also have nocturnal dyspnea, meaning the patient could wake up in the middle of the night gasping for air, especially if they're in a semi-Fowler's position. Fourth is tachypnea. They're going to have rapid breathing, trying to compensate for all the oxygen that they're not getting. Their compensatory mechanism is going to kick in, causing tachycardia. First compensatory mechanism that's going to kick in is the sympathetic nervous system, which is the fight or flight. Therefore, patients' vital signs are going to increase, so they're going to be tachycardic, have high blood pressure. So that leads to the fifth one, tachycardia due to sympathetic nervous system. The sixth sign and symptom that you could see in a patient is going to be orthopnic. They're going to be leaning against the food tray, sitting in a tripod position, trying to expand their lungs as much as possible to obtain that O2. They could become hypocapnic, meaning they're going to have their carbon dioxide levels are going to be differentiated. The use of their accessory muscles are going to be used. to obtain as much oxygen as possible because the body's trying to compensate. And we're also going to see nasal flaring of the patient because we typically don't use our nares to breathe, but that's just a sign and symptom of left-sided CHF. So just keep in mind that blood flow is flowing back from the left ventricle to the mitral valve into the left atrium to the lungs, causing disturbance within the alveoli and gas exchange. Okay, so it's important to talk about the dysrhythmias that's associated with left-sided CHF or right-sided CHF. But let's talk about left-sided CHF. Left-sided CHF, a dysrhythmia that could be caused is atrial fibrillation and aflutter. Well, how does AFib, aflutter occur when a patient has left-sided CHF? Well, let's talk about it really quick. So blood flow is flowing through, let's say the left ventricle is hypertrophied, it's not working properly. The aortic valve is narrowed, it's stenosed, it's unable to pump out blood to the systemic circulation. So what happens is that the blood has to go somewhere else. So where does it go? It goes from the left ventricle back into the left atrium. So why is that an issue? It is because the left ventricle is considered to be a highly pressurized system. Typically the blood is pushed out at a rate of 120/80, and when that pressurized blood is pushed back into the left atrium, which is considered to be a low pressurized system, the atrium is going to quiver like this, and what's going to happen is that the patient's rate is going to increase, and now the patient has a high chance of obtaining a blood clot traveling into the pulmonary system, such as the lungs, or traveling up into the neck, into the brain, into the cerebral arteries, causing a stroke. Well, why would a blood clot occur? It's because when blood is just sitting within the atrium, it's not going anywhere, it's stasis, it's just sitting there, not doing much, so blood is going to clot, forming a thrombus. Now that thrombus could travel in any direction it wants. So typically, what are patients placed on when they have atrial fibrillation or aflutter? Well, we need to control the rate by using a cardizem drip or possibly digoxin or beta blockers. For anticoagulants, we want to place them on a heparin drip, but it's just important to make sure to know their heparin levels as well. How can ventricular tachycardia occur and ventricular fibrillation occur? Well, since there's low cardiac output, and low tissue perfusion, this tissue perfusion is a major factor in why ventricular tachycardia occurs and ventricular fibrillation occurs. It's because the buildup of lactic acid, which is a byproduct during anaerobic metabolism, increases. Therefore, the heart is panicking, and now some nursing intervention that's important, that's associated with ventricular tachycardia and VFib. If you see it on the monitor, patient is unconscious. It starts with CPR, convert them into a normal sinus rhythm.